Hi, everybody. Thanks so much for joining us. We have an exciting session for you. It's called Testing for 2030, Novel Strategies for the Home Stretch. What do we need more? I can't think of anything else that we need now more than ever as we kind of near the last mile. And we'll be having a number of wonderful presentations for you about innovations and strategies to really get us to that last mile today. So without further ado, I want to introduce our first speaker, Gift Kamanga from Malawi. He's an experienced public health and clinical practitioner, skilled in public health program implementation in HIV/AIDS services, sexual transmitted infections, family planning, maternal neonatal health, and key populations programming, clinical operational research, monitoring, and evaluation. So Gift, please come to the podium, and we are eager to learn from you about the strategies which are really going to get us to 2030.
Good afternoon. My name is Gift Kamanga from FHR 360. I work on Linkages project in Malawi, Lilongwe. I have no conflict on this presentation. I'm actually presenting on delivering of a comprehensive package for HIV prevention, care, and treatment for the key population. Malawi has very high burden of HIV, and it's actually even worse among the key population. Female sex workers, 62.7%, and MSM is reported through some research that's 17.5%. Malawi government, fortunately, has commitment to servicing key populations through its strategic documents, the HIV strategic plan. But implementing things on the ground has really been a problem given the social, moral, and legal environment in Malawi. That's why the PEPFAR-funded Linkages project came in to meet the demand for HIV prevention, care, and treatment for the key population. As a mirror of our implementation in the first 6 months of our program, you can see that from our female sex workers estimate, all levels of services at each point of the cascade were really miserable. And I just want to highlight that the linkage to treatment was extremely low at 4%. Learning from that 6 months period, and also really standing on our programmatic strategy, which we set from the beginning, our key has been to understand the key population through program mapping and also the place study which we had. And we invested a lot in PA leadership, especially training them in micro-planning and also routine supervision. And we have been very good at effectively engaging with government structures at all levels and key populations themselves, and also civil society organizations. So this really helped us to deliver good services to the key population, starting with HIV prevention messages, STI screening and treatment, violence prevention and mitigation, condom lubricant use, HIV testing, ART, retention, and viral load suppression. This is a busy slide, but I just want really to highlight the fact that the programmatic mapping has really taken us through the understanding of our key population dynamics and the increases in sizes and hotspots, which have really helped us to provide and plan necessary services to find where these key populations are. This slide much have actually been already talked about, but I really just want to emphasize that Linkages project is the first project in Malawi to implement complete cascade of services. And what is key here is really to say this is just summarize everything that has been done. But when we deliver key population services, we have to say one of the most important things is to make sure that we create an enabling environment. And we did that through engagement of the Malawi police and also other legal and advocacy partners, and also learning from the place study and lessons from the outreach teams, and also good relationship with other stakeholders and service providers in the districts where we operate. All these have really been key to our programming. And the most important thing of that is that our good relationship with the implementing partners and also good support that we received from the Department of HIV, of Ministry of Health and NAC really got us where we are now. And when we implement services for KEEP operation, we really have to invest in the KEEP operation themselves to help their peers to take through the program. In this, we trained a lot of them as peer educators and also peer navigators, including their supervisors who are called outreach workers. And we established several support groups to really help them support themselves and also as an opportunity for delivery of other community services, including GBV and crisis management. And we couldn't just train just the KEEP operation leaders themselves, but we have to make sure that the program people and the healthcare workers are also prepared for the task. So we also trained a number of them. Our operation is through differentiated service delivery models, including DIC, outreach clinics, hybrid, which I mean private and other public health facilities. These have really been key, but I think I'm going to single out the drop-in center, which is acting as a key space for the KEEP operation, and at the same time, it also acts as a service delivery point. In addition to that, we are also employing an additional strategy called Enhanced Peer Approach, or EPOA, and actually this strategy is a network incentive-based initiative which reaches out to other KEEP operations which could not have been reached by ordinary strategies of outreach. Having done all that, now we have a better story to tell. We have reached thousands of female sex workers with services, and you can see that our link to HIV testing is very good, and linkage to treatment is 100%. And I have to say that this linkage is 100% because of that opportunity of having so many outlets through the drop-in centers and also use of other facilities where they can get these services. And what is also important in this slide is the fact that among those that we had their viral load, there's very good viral suppression. But we know that we have to increase the magnitude, so we are currently working on the strategies to make sure that as many people get on the viral load testing and follow-up. About knowing trends of HIV status and linkage to treatment, giving services to the same community, we have noted that over time there's a reduction in the case finding. But we are actually not just stopping there. That could be saturation, but at the same time, it could mean that we have to do some more work actually to identify even higher risk hotspots. And at the same time, I have to say that we continuously engage those people who are HIV negative with preventive messages so that they remain uninfected. And from this, you can also clearly see that the linkage to treatment is very good. The trend for case finding among MSM is not that different from the female sex workers, but in this slide, which I'm not going to give so much details because we have a poster outside which we can actually share more information. But here I just want to highlight the fact that the initiative I talked about, EPOA, can really produce some magical output. As you can see that where it heightened, it was really the effect of EPOA. So our plan is to make sure that we find some strategies to make sure that doesn't just stop at EPOA, much as we know that we can add or we can have other EPOAs, but we have to make sure that that is sustained. We have learned a lot of lessons in our programming. As I said, very difficult operational environment, but we had very good support from the Ministry of Health, and also our continuous engagement with the other partners at the district level helped us a lot, and the empowerment of KEEP operation themselves have really made us get these results. And the evidence-based programming, where we routinely do the programmatic mapping and intensive micro-planning and other support to the peer leaders, have really been key in this. And the use of differentiated model, as you saw the evidence from a good linkage to treatment. But finally, I have to say, working with key populations in Malawi, it has really been difficult because of the stigma environment, including healthcare workers, program people being stigmatized. But I really thank all the program people and healthcare workers from our implementing partners and from FHI for taking that challenge upon themselves that they need to deliver these interventions to vulnerable people. And at this point, I have to say thank you for listening.
So we have time for a few questions. Please come to a microphone if you have a question. We can take one or two. Okay, great. Thank you so much, Gift. We'll also have a discussion at the end, so we can come back and discuss further. Okay.
Yeah, my name is Tung and I'm from Vietnam. I'm from Lighthouse Social Enterprise, and I'm really pleasure to introduce the next speaker, Dr. Hieu Ngo from PATH Vietnam. Dr. Hieu has 30 years of experience in healthcare. He leads the innovations in HIV community testing in Vietnam. The Ministry of Health has expanded this innovation nationally since late of 2017. Dr. Hieu is Technical Director of Healthy Markets Project at PATH. So welcome.
Thank you very much for the very nice introduction. Good afternoon, ladies and gentlemen. My name is Ngo Van Hieu. On behalf of PATH Vietnam team, I would like to present you a presentation on key population-led health services, community-based organization, lay health worker transform HIV testing in Vietnam. I would like to start with some background information. Before 2015, HIV testing service was only offered in public health facility. That led to low and steady uptake of the annual HIV testing among key population. It was around 30%. The figure on the screen showed the uptake of HIV testing among key population in 3 consecutive years. In late 2014, Vietnamese government committed global 90-90-90 target and did open the door for many differentiated services. And HIV-led provider and self-testing is one of the initiatives. And you can see at the photo, the Deputy Prime Minister of Vietnam participated in the 1990 launching in Vietnam. With approval from Ministry of Health in October 2015, USAID PATH Healthy Market pilots HIV-led provider and self-testing services with the 3 following objectives. Number 1, to accelerate HIV testing uptake among key population as a part of 90-90-90 target. Number 2, to determine feasibility and acceptability of HIV-led provider and self-testing among key population, community-based organization, and health staff. Number 3, to measure effectiveness of the referral from HIV community testing to confirmatory diagnosis and ART enrollment. In this program, we pilot 2 models, urban and rural model in Hanoi, Ho Chi Minh City, Dien Bien, and Nghệ An. You can see some differences and similarity between the 2 models. In rural model, we train KP-led community-based organization staff as a lay provider, while in rural model, we train the village health worker. In rural model, we use only blood-based test kits, but in urban model, we use both blood-based and oral fluid-based test kit. The purpose of this is to provide more choice to clients and to test the acceptability of key population on the oral fluid-based test. In this slide, I would like to summarize the implementation process. In October 2015, the Ministry of Health approved HIV lay provider and self-testing pilot implemented by PATH Vietnam and by PATH and WHO in Vietnam. Right after the approval, in December 2015, we started the pilot in the 2 rural provinces and then expanded into urban sites in the early of 2016. We conducted midterm review after 1 year and a final review after 2 years to review the final, the achievement as well as the lesson learned from the pilot. The HIV lay provider and self-testing services was acknowledged to work very well in Vietnam, and the Vietnamese Ministry of Health and VAC decided to scale up the services nationwide by approval of the National Guideline on HIV community testing in the April of this year. And currently, about 32 out of 63 provinces offer these services to clients. Up on the screen, you can see the cascade of HIV lay and self-testing in 2 years. You can see that the positivity yield is 4.3%, which is much higher than, less than 2% yield among key population testing in the public side. And more importantly, the connection to the confirmatory tests and to care and treatment is very high. It's over 90%. The findings from our quality survey also prove that HIV lay provider and self-testing is very convenient for our client. An MSM client in Ho Chi Minh City said that the community-based testing is so convenient and friendly. I can be tested at any time, any place, and I feel very comfortable doing so. The test is also fast, and I don't have to wait long for the result. Or a lay tester in the rural area found that our client know and trust us, and the procedure is very simple and convenient. One of the aspects that clients value most is that they don't need to travel to get tested like before. Or a lead of the KP-led social enterprise shared with us that since we deliver HIV lay testing, we feel very confident and empowered. Our community trusts us, and our role have increased among CBOs in Vietnam. This graph presented the result from operation research that 2/3 of the clients tested by lay provider are those who have never been tested for HIV before, and this may vary among key population groups. From this pilot, we learned that we withdraw some lessons learned. Number one, lay tester was capable of offering HIV testing with exceptional skill, and engagement in HIV lay testing boosts the CBO confidence and pride of their work. Number two, lay tester is highly effective in facilitating HIV diagnosis and ART enrollment. Number three, among those tested by lay tester, more than half was a first-time tester, and 4.3 was a newly HIV diagnosis. It's versus less than 2% in the public side. And the last, fostering close MOH engagement in and observation of the lay testing translate into the significant trust and support of these new services. As mentioned by Professor Long, the Director General of the VAC Ministry of Health at the end pilot review workshop, he said that HIV testing offered by lay provider increased access to testing. Initial results demonstrate that it has been successfully in the reaching key population that have never tested or infrequently tested for HIV, and yet it was at high risk of HIV. This lesson has a help in the advocacy process to achieve Ministry of Health approval for the National HIV Community Testing Guideline in April of this year. And HIV-led testing scaled up by Ministry of Health, PEPFAR partners, Global Fund, and WHO, reaching over 100,000 key population. Stepwise rollout of HIV-led testing has opened the door for the KP-led HIV services, including KP-owned private clinic offering PrEP and ART. As mentioned by a lay provider, a staff of a social enterprise, the program is responding to the real need of a community that has been waiting for this a long time. And we see there is a great potential for fee-based services to sustain our work in the future. I would like to close my presentation by acknowledging the many CBO, social enterprise, and private clinics who are presenting here at the conference for their implementation of the services. The leader and the staff of the Ministry of Health, VAC, for their leadership and coordination during the piloting. USAID Vietnam representative, and of course, leaders and members of my team at PATH Vietnam, and my colleagues from WHO Vietnam. Thank you very much.
We have time for a few questions. If you have any question, you come to microphone.
Hello. Yeah, hi, I'm Gabe Shammy from the US. That was a very nice presentation, thank you. I was really impressed with the scale up as well. I was curious, you had mentioned in the urban clinics that there was a mixture of oral-based self-testing and then blood testing. I was just curious if there was differences in uptake of those two modalities, if I understood it correctly. And have they, when you've ramped up, has oral self-testing been included in the scale up? Thanks.
I see my colleague is smiling at me. She's from US. He is one of the technical experts in oral test kit. So yes, thank you very much for the question. When we piloting this, we started with blood-based test kit. But after that, we have not a big amount of the oral fluid. And one of the things is we want to offer more choice for clients in the urban area. And one of the purposes is, in addition to that, we want to test acceptabilities of the key population in the urban area. And we think about such long-term strategy for sustainability of the fee base, so that we test in the city only.
Thank you. So the next question.
Okay, thank you so much for your presentation. Quick question on your community testing. Could you explain where ART initiation was done? And I assume it might have been done in the community. If so, could you also explain whether the people that tested positive and were initiated on ART continued in the community or were eventually brought to health facilities? And if so, how? And then thirdly, if you can explain, if you have any data around the percentage that was able to be brought for continuing care in health facilities after community testing and ART initiation. Thank you.
So thank you very much for the question. My understanding is the follow-up case after the testing, right? Is it right? No. ART is still not yet in the community, but it is also provided at the clinic. Sure. One of the things is, one of the things when we piloting this is what we concern at the beginning is how to follow up and how to support with the reactive case identified by the community. So that we work very closely with the community so that they have a close relationship and close support for those who are reactive tested, who are reactive result, so that they can follow up with the confirmatory testing at the clinic and after that on the ART. So that the ART is, the ART enrollment rate is among those who need that is over 90%.
Excellent. Thank you so much. I'm just going to go and introduce our next speaker. So Alison McFall from the United States is a PhD candidate in epidemiology at Johns Hopkins Bloomberg School of Public Health, focusing on optimizing HIV testing, prevention, and care for key populations globally. She'll be presenting to us on respondent-driven sampling and ways we can use it in case findings. So thank you.
Thank you. Thank you for the introduction, and thank you to the conference organizers for inviting me here today to talk about some of our research entitled Respondent-Driven Sampling More Efficiently Identifies Undiagnosed HIV-Infected People Who Inject Drugs, or PIWID, than PIWID-targeted community integrated care centers in India. And I have no conflicts of interest to disclose. So just starting with a brief background, as many of you already know, injection drug use drives the HIV epidemic in many settings, including low and middle income countries. And people who inject drugs are often not adequately engaged in HIV services, and this is for a variety of different reasons, including little HIV knowledge, perceived low HIV risk, stigma, criminalization, difficulty accessing services, and ongoing substance use. And this all results in low awareness among HIV-infected PIWID. And so this is what we found among people who inject drugs in India across 15 different cities. Diagnosis was the largest drop in the HIV care continuum, with only about 40% of those HIV-infected being aware of their diagnosis. And so this points to a real need for more approaches to reach and engage undiagnosed HIV-infected PIWID. So data for this analysis comes from the National Collaboration on AIDS trial, which is a cluster randomized trial in 26 different cities in India, both among MSM and PWID. And the goal of the trial is to evaluate the effectiveness of integrated care centers, known as ICCs, on the uptake of HIV testing. For this analysis, we restricted just to the PIWID stratum, and then the 6 cities with the intervention, the ICCs. So this is a map of the 6 cities with the ICCs. We have 3 in the Northeast, 2 in the North, and 1 in the Central region. So ICCs provided services in these 6 cities that were PIWID tailored from approximately 2014 to 2017. And services included HIV counseling and testing, needle syringe exchange, opioid agonist therapy, STI screening and treatment, appropriate referrals, among other services. A nurse and counselor were available on site every day, and a doctor was available several times a week. We used peer outreach workers to encourage PIWID in the community to visit the ICC and also to track clients that needed to return for repeat services, such as a repeat HIV test. We used a biometric tracking system, specifically using fingerprints, to track unique clients, the services they used, and their lab results. ICC service utilization was completely voluntary, and utilization was not compensated. For the trial, the evaluation data collection was conducted using respondent-driven sampling from 2016 to 2017. And I just want to step back for a second and describe respondent-driven sampling for those that are not already familiar. RDS is a type of chain referral sampling method to reach so-called hidden or difficult-to-reach populations. So it utilizes peer network connections to recruit study participants for research studies and surveillance. And this is for populations in which a sampling frame is not available. And this is now widely used in HIV research, especially among key populations. So 2 seeds were used to initiate recruitment in each of these 6 cities. Seeds are PIWID that are well connected and influential in their community. All seeds and subsequent study participants received 2 recruitment coupons to give to other PWID that they know in their community. All study participants were compensated for participation and eligible referrals. And we recruited a total of 1,000 PWID in each city. In order to enroll in the RDS, an individual had to be 18 years or older, self-report injection drug use in the prior 24 months, provide informed consent, and have a valid RDS coupon. All study participants completed an interviewer-administered survey and received an on-site rapid HIV test and counseling. We again used a biometric tracking system to track duplicate enrollments into the RDS, but also to identify participants that were also ICC clients. So to summarize, the ICCs in these 6 cities provided services from approximately 2014 to 2017, and then an RDS sample was conducted from 2016 to 2017. So given these 2 data sources or 2 approaches to reach people who inject drugs, we wanted to assess the ability of RDS to identify undiagnosed HIV-infected people who inject drugs compared to a venue-based strategy, in this case, integrated care centers in India. So we used 2 different measures to summarize the efficiency of RDS versus ICCs in reaching undiagnosed HIV-infected PWID. The first is the number needed to recruit, or the NNR, which is the number screened or recruited in order to find one undiagnosed person. So for the NNR, the lower the number, the more efficient a strategy. And then we looked at the identification rate, which is the number undiagnosed identified per week. So for the identification rate, the higher the number, the more efficient a strategy. Undiagnosed individuals were those that tested positive either at the ICC or at the RDS study visit and denied a prior diagnosis. We also looked at characteristics associated with identification by RDS only and RDS and ICC, both in comparison to ICC only, using multinomial logistic regression. So jumping into the results, there were a total of 14,397 unique individuals, 8,385 of which were ICC clients only, 3,638 of which were RDS participants only, and then there were 2,374 which were ICC clients that were later sampled into the RDS. So looking at correlates of identification by RDS only in comparison to ICC only, men were more likely to be identified by the RDS compared to ICC only, as well as those that were widowed, divorced, or separated, and those with a higher education. Those that were HIV infected but undiagnosed were 2.5 times more likely to be identified by the RDS versus the ICC only. Now looking at the correlates of identification by both the ICC and the RDS, again in comparison to ICC only. Again, men were more likely to be identified by both, and HIV-infected but undiagnosed individuals were about 1.5 times more likely to be identified by both ICC and the RDS in comparison to ICC only. So this figure shows the number needed to recruit, or the NNR, for undiagnosed individuals by city and strategy. So the NNR for the RDS is in the orange, and for the ICC is in the blue. And so overall, and in each city, with the exception of Bilashpur, the NNR for RDS is lower than the ICC. And for the identification rate per week for undiagnosed HIV-infected individuals by city and strategy, again, RDS is in the orange, and the rate for ICC is in the blue. And overall, and in each individual city, the rate was higher for RDS in comparison to ICC. So there are several limitations to our work. Awareness of HIV infection status was self-reported, which is subject to biases. The 2 approaches, RDS and ICCs, were not completely concurrent, so therefore there could have been migration or other temporal changes. And we're unable to separate out the effect of a network-driven strategy and monetary compensation within RDS on its efficiency. So in conclusion, compared to a venue-based strategy, in this case the ICCs, RDS required screening fewer people who inject drugs and more rapidly identified undiagnosed HIV-infected PWID. Thus, network-driven strategies with compensation could be used to identify and engage groups that are not currently visiting venues. Before I end, I'd like to thank my co-authors, the study staff, and especially the study participants, and our funding. Thank you.
Thank you so much, Alison. We have time for 1 or 2 questions, if there are any. Okay, I can see.
Hi, this is Gabe Shammy again from the US. I was just curious, great presentation, it's interesting to see. Why do you think that your finding on HIV with RDS was, the odds of finding someone through RDS were higher than ICC? I mean, I can understand the yield in part also because your ICC-N was much larger than the RDS, or a good proportion larger. But I was just curious if you had thoughts about why the odds might be increased of HIV infection through that strategy. Thanks.
Thank you for the question. I think for a variety of different reasons, I think there are people that are unlikely to come to a clinic or a venue, but when they get a coupon or a friend tells them, they're more likely to. So just self-referral is going to be different for certain people. And yes, the number of clients was much larger for the ICC in comparison to the RDS. I did do a sensitivity analysis, though, restricting to the first 1,000 clients at the ICC so that the sample size was the same, and there were still differences.
And what was the HIV status of the seeds?
It varied. Some were negative, some were positive.
Thanks.
Excellent.
All right. I want to introduce the next speaker, one of my very lovely sister from Thailand, Rina Jam Anoysok. Rina is program coordinator at the Thai Red Cross AIDS Research Center, where she coordinates the transgender-related HIV research studies and plays significant roles in establishing the Tangerine Community Health Center, the first transgender health clinic in the region.
Thank you very much, John and Cheryl, and it's my pleasure to be here. So today I'm going to talk about the roles of the gender-affirmative hormone services plays an important role to increase HIV testing and other sexual health services among transgender women in Bangkok, Thailand. And I will share the lesson learned that we use from that we got from the Tangerine Community Health Center that we're running. And so my outlines of the presentation is, I will start with the background, objective, methods, results, and the conclusion respectively. And the background of the abstract was the evidence is very limited on the roles of gender-affirmative hormone treatment services in HIV programming for transgender women. And I would like to start the presentation with the population size estimation and HIV epidemics in Thailand among trans women. It was estimated that there were around 300,000 of transgender women in Thailand. And of those, 60,000, they were sexually active. And of those who sexually active, there were around 15,000, they were at high risk of HIV acquisition. And the HIV prevalence among trans women in 2016 in Thailand was around almost 14%, with the 2% of the HIV incidents. And in terms of stigma and discrimination in healthcare settings, it was reviewed that by a research conducted by the Transgender Alliance and the Transgender Europe that almost 50% of the transgender person, they never receive advice and counseling from healthcare providers on the gender-affirming care and hormone use. And almost 50% they had negative experience in healthcare from healthcare providers. And another research reported that 15% of healthcare workers, they thought that HIV-positive transgender women should be ashamed. So it was leading to double layers of stigma and discrimination against HIV status and transgender identity in Thailand. So in 2015, with the support from USAID and PEPFAR, the Thai Red Cross AIDS Research Center, we organized the first national trans community consultation. We opened the safe space for transgender communities in the country to come together and to exchange their experiences on their unmet health needs and exchange their services and their expectation in terms of healthcare services with the healthcare providers. So in 2015, in November, the Tangerine Community Health Center was launched. The name of the Tangerine was mutually agreed by the transgender communities with the slogan, "Where transition fulfills identity." It's the first transgender comprehensive sexual health and well-being service in the region. The clinic was founded from a robust trans community consultation together with healthcare providers at the Thai Red Cross. The clinic was led by four trained transgender staff and two gender-sensitive nurse and physician. And as I said before, the service has been integrated in the public health setting. We offer gender-affirming hormone service treatment for the transgender people, and it was located at the Thai Red Cross Anonymous Clinic. And now in order to do the demand generation strategy, we use the online platform to do the outreach activities. We work with the transgender social influencer in the country to talk about hormone level monitoring and other health services for transgender women. And we invited sensitive healthcare providers to talk and exchange their experience and knowledge and information with the transgender social influencer. So in the past 6 months, it was very successful. Here are some of the examples of the banners that we use. Young transgender women to promote the services at the Tangerine Community Health Center. So here's the outreach performance. From the October last year until end of June this year, we have 700 transgender women clients coming at Tangerine. And of those, 71% they came from social media. Of those who came from social media, they reported that they came from Facebook page, 92%. And the HIV testing was around 91%. 37% they were HIV first-time testers. And the HIV prevalence was 7%. And the objective of the abstract that we submitted is to examine the potential role of the gender-affirmative hormone treatment as a service entry point to facilitate the service uptake of HIV, syphilis testing, and PrEP. And we assess the characteristic of the transgender women clients and their access to gender-affirmative hormone treatment and other health services. We also compare the uptake of the HIV and other health services between transgender women who access to hormone treatment therapy and who did not access to hormone treatment therapy. And here's the progress to date as of May this year. So far, we have 1,600 of transgender clients with more than 5,000 visits at Tangerine. Of those, 1,374 they were transgender women. And the HIV testing uptake was 91% with 12% of HIV prevalence. In terms of syphilis, 60% they have syphilis testing and 12% they were tested syphilis reactive. Of those trans women, 21% they have undergone sex reassignment surgery. And of those who have SRS or sex reassignment surgery, 20% they carry oncogenic HPV types in neo-vagina. And here's the result of the characteristic of the transgender women at Tangerine. You can see that almost 60% they have below bachelor degree education, and almost 30% they were unemployed. Almost 20% they engage in sex work, and 56% they use alcohol, while almost 10% they use amphetamine type stimulants. And here's the double-sided HIV cascades performance. You can see on the green bar on your right-hand side, it represents the HIV positive transgender women client at Tangerine. Of those who were tested positive, 92% they were successfully initiated ART at the Tangerine. And of those who initiate ART, 90% they have viral load suppression after 6 months. Moving to the blue bars, it represents 88% of HIV negative trans women at Tangerine. You can see that 11% they receive PrEP, while we have still low uptake of PrEP user among the transgender women at Tangerine. This is still challenging. And here the result, you can see that we compare the transgender women clients for two groups. The first group is the transgender women who receive hormone services, and another group is those trans women who did not receive hormone services. You can see that the transgender women client who receive hormone-related services, they were more likely to have subsequent visits, and they were more likely to have repeat HIV testing, syphilis testing, and they're likely to have PrEP uptake, respectively. And here's a story that I would like to share with you. She was a young transgender woman at the age of 14. She visited the Tangerine with her mother, and she knew about our services from Facebook page promoted by the transgender social influencer. The hormone treatment therapy was her primary purpose. And when met with a transgender counselor, she reported of sexual abuse by a school senior. She finally accepted HIV testing offered by a transgender counselor, and the testing result was HIV positive. However, she was successfully initiated ART on the same day of the diagnosis. A few weeks later, she was referred to the HIV pediatrician, where we established referral linkages at the Chulalongkorn University Hospital. And it was impressive to know that her mother was really supportive for her gender transition as well as her ARV adherence. And here's the conclusion I want to share with you from the Tangerine. It's proof that transgender community-led and community-owned response play a critical role in the HIV responses. Integrated gender-affirming hormone services has been proved feasible and effective in increasing HIV and other sexual health service uptake. Gender-sensitive and well-trained staff are key in delivering the HIV and health service package for transgender women and other key populations. We also organized an annual meeting for transgender community and healthcare providers to share their knowledge and experience in order to improve the quality of the service at Tangerine. We also having transgender who are living with HIV who play an important role at the front line of the clinic and provide support to those who were affected by HIV. And the service at the Tangerine provided is affordable fee-based service, which leading to sustainability in the long run. So, and I would like to express my sincere appreciation to the leadership of my organization, Professor Prapan, Dr. Nitya, Dr. Fritz, the Tangerine and the prevention staff, as well as the donor, the USAID and the PEPFAR, under the USAID Thailand Linkages Project. And last but not least, thanks to the Thai transgender communities. Thank you very much.
So, thank you very much. If you have any question, please come to the microphone. Thanks. Yeah.
Hi, I'm Gerald Sharp from the NIH in Bethesda, Maryland. I just wondered, I know the transgender women are a really high-risk group for HIV infection, and they're somewhat of a difficult group to reach. And I just wondered, what do you think about having the doctors that treat them for hormone replacement therapy, for hormone treatment, to also administer PrEP? Are they willing to take PrEP, or is there some? I mean, what's your perception of trying to get to them through their physicians?
Those who get PrEP, that we have around 10% of the transgender women client at Tangerine, and this is still challenging. So we try to, a few concerns raised by the trans women community was that the first one is drug-to-drug interaction between PrEP and hormone treatment, hormone regimen that they're taking. And another factor is about the willingness to pay. Sometimes, most of the trans women that we have, they prioritize hormone treatment expense rather than PrEP regimen. And you know that PrEP has not been supported under the universal health coverage in Thailand, so they have to pay for the services. However, for those who are in need, we still can provide the free PrEP to them as well. But another thing is about the demand generation. Many transgender women, they still don't know what PrEP is. So we're still lacking of the citywide campaign addressing on PrEP and transgender women. So we're trying to increase these and collaborate with the Bangkok Metropolitan Administration to scale up PrEP at the citywide campaign. Thank you. I don't know if I answered your question.
Okay, thank you so much. We'll have more questions and discussion at the end. So I'm just going to come to our final speaker before we start the Q&A. Please welcome Catherine Ryan from Australia. Kathleen Ryan, I apologize. Kathleen Ryan from Australia. Kathleen works in HIV prevention in Melbourne, Australia, and her projects include evaluating community models of HIV testing in the Victorian PrEP-X demonstration project and surveillance of HIV. Thank you.
Thank you. Okay, so I'll start with a little bit of background about HIV in Victoria, Australia. So Victoria, Melbourne is the capital city of Victoria, where the data that I'm presenting today is located. So we get approximately 300 new HIV diagnoses annually, and we have a really highly concentrated HIV epidemic, with about 75% of new diagnoses reporting male-to-male sex as their exposure route to HIV. What we've seen in recent years is that we're getting an increasing proportion of diagnoses amongst overseas-born men who have sex with men. So we've got a declining rate of diagnoses amongst Australian-born men who have sex with men, but as you can see in the red dashed line, we're getting an increased rate of diagnoses amongst the Asian-born men who have sex with men. So it looks like whatever the prevention tools that we're having are having some effect, but that is a bit inequitable at the moment. So HIV testing in Australia is one of our main prevention tools, as it is in many places. All gay, bisexual and other men who have sex with men are recommended to test for HIV annually, and men reporting higher risk for HIV are recommended to test 4 times per year. HIV testing is free for Medicare eligible people in Australia. So Medicare is our universal healthcare system, and all Australian citizens, permanent residents, are eligible for Medicare in addition to citizens of some other countries that Australia has a reciprocal healthcare agreement with. However, people from other countries and people on things like student visas and working holiday visas are not eligible for Medicare, and they're required to pay upfront for their medical services, including HIV testing. Pronto is a community-based HIV testing service located in Melbourne, and it was designed to reduce barriers to HIV testing and to increase testing frequency amongst gay, bisexual and other men who have sex with men. And it provides free rapid HIV tests to all people who attend, regardless of their Medicare eligibility. So while Pronto was designed to reduce a number of barriers to testing and increase testing frequency, evaluation of the service showed that return testing or frequent HIV testing was no better at Pronto than at other clinical services in Melbourne. And what we found was that the lack of STI testing at Pronto introduced a barrier to return testing. So Pronto only delivered rapid HIV tests. It didn't offer any other sexual health care. Following evaluation results, comprehensive STI testing was introduced at Pronto in February 2016. So there's a bit of a challenge though, because while rapid HIV tests are free to all people who attend Pronto, the STI tests are funded through Medicare, so they're only free to people who are Medicare eligible. So people who do not have are not Medicare eligible are required to pay upfront and then claim back for their testing. And that costs about $160 Australian, which is about €100. So the aim of this presentation is to look at the impact of the introduction of STI testing at Pronto on HIV testing. So did this reduce barriers and then facilitate improved testing frequency? And we've decided to look at this separately for people who are Medicare eligible and people who are Medicare ineligible to see if that cost maintained a barrier for the Medicare ineligible clients. So I'll be presenting data that we collect through the Access surveillance system. And so this system is a linked surveillance system where testing data is automatically extracted from the patient management system. It's de-identified and it cannot be re-identified. And so what it allows us is to see the test requests, the results, and the date of the test, and we can follow an individual over time so we can see if they're returning. We also have behavioural surveillance data. So at Pronto, whenever anyone attends, they're invited to complete a behavioural survey, and we have about 70% completion on this. The inclusion criteria for the study is attending Pronto for an HIV test and being aged over 16. And we've excluded anyone who is attending for PrEP because you're required to attend 3 monthly for your PrEP prescription, and you have an HIV and STI test at that time. So including those would be inflating our return testing. I'll be describing Medicare eligible and ineligible client characteristics, describing the STI testing uptake and positivity, and then looking at 6-month return testing before and after the service changes at Pronto. So when we submitted the abstract for AIDS, we used a country of birth on the survey as a proxy for Medicare eligibility. And we found that overseas-born clients were less likely to uptake STI testing with their HIV test. But since this time, we've actually made updates to Access, and we're able to now see if someone is Medicare eligible. So we can disaggregate overseas-born clients by Medicare eligible and ineligible. And we see here that the Medicare eligible overseas-born clients had exactly the same uptake of STI testing with HIV testing compared to Australian-born clients. In comparison, the overseas-born clients who were Medicare ineligible had very low uptake of STI testing. So for the rest of the presentation, when I talk about Medicare eligible, it's both the Australian-born and the overseas-born Medicare eligible clients, and then the Medicare ineligible is just the overseas-born Medicare ineligible clients. So looking at the client demographics, Pronto clients are predominantly cisgendered male, reporting sex with men. But if we look at previous testing history, we can see that the Medicare ineligible clients were significantly less likely to report a HIV test before their first test at Pronto, and they're also younger than the Medicare eligible clients. And then when we look at sexual behaviours of the Medicare eligible and ineligible clients, we can see that at every behaviour that we recorded, Medicare ineligible clients, fewer of them reported higher risk practices. So there was less inconsistent condom use, there was less group sex, there was less drug use with sex. But while they're reporting lower risk, they're still getting, oh sorry, ignore that. So now moving on to the STI testing. So as I said before, about 85% of the Medicare eligible clients took up STI testing with their HIV test, but just 7% of Medicare ineligible clients had an STI test with their HIV test. We didn't do any statistical analyses on the STI positivity because the numbers were so low. But when we look at HIV positivity, we can see that the Medicare ineligible clients are as likely or have a similar proportion of HIV positivity with the Medicare ineligible clients. So moving on to changes in HIV return testing. So what we did is a segmented linear regression. And essentially what this means is that we have looked at the slope before the intervention happened, then we look to see if there's an immediate change in the slope, and then to look at the slope after the intervention occurred. So our intervention is the introduction of STI testing. And our outcome is the monthly percentage of tests with the previous test within 6 months. So 6-month return testing, essentially. So looking first at the Medicare eligible clients, and we can see in the pre-intervention period, 6-month return testing hovering around the high 20%, and that was pretty stable in this period. And when STI testing was introduced, this jumped by about 6%, and then following STI testing introduction, it was increasing by about 0.5% every month. So it looks like it was having a really positive impact on return testing amongst Medicare eligible clients. Conversely, when we look at the Medicare ineligible clients, 6-month return testing was declining slightly in the pre-intervention period from around 20% down to around 15%. There was no shift at intervention, and return testing flatlined afterwards, which is what we would expect there not to be a big impact because there was no real uptake of STI testing. But importantly, when you look at the two figures side by side, you can see that following the introduction of STI testing, return testing shifted amongst the Medicare eligibles and not amongst the ineligibles, and so the inequity amongst the Medicare ineligible clients is actually increasing over time. So to summarise, Medicare ineligible clients are younger, they're less likely to have tested for HIV before testing at Pronto, and they reported less risk for HIV transmission. However, the HIV diagnoses were similar amongst the Medicare eligible and ineligible clients. There was very little uptake of STI testing amongst Medicare ineligible clients, and we think that the cost is a significant barrier to these clients uptaking STI testing. And then we also see that following the introduction of STI testing, return HIV testing increased significantly amongst the Medicare eligible clients, but there was no shift amongst the Medicare ineligible clients. So what do we have to do to get to 2030? I think funding is needed. We need to fund STI testing for Medicare ineligible clients so that they're not getting a different service to those who have access to Medicare. There also is maybe need for more appointments to be funded. If we're getting more clients returning frequently, but we have no increase in appointments, we might be blocking people out of the system. I think there's also a need for marketing. Perhaps we need different messaging, or we need to use different platforms to inform Medicare ineligible clients, these overseas-born clients, that they need to be testing frequently, that they can access free testing and the benefits of testing. And we need to figure out how to reduce HIV transmission amongst the migrants. We need to understand why we're seeing an increasing rate of HIV amongst Asian-born MSM when we're seeing a declining rate of HIV amongst the locally born MSM. Is there different sexual networks? Is there a pool of undiagnosed HIV due to the barriers of HIV testing? Are there missed opportunities for STI testing and prolonged STIs within this population driving HIV transmission? So there's still a fair bit of work to be done. I would like to acknowledge the Pronto clients who give so much data and who are so great in giving their data, and to the Pronto staff and Thorn Harbour Health staff who are so great in helping us get the data, and to the Access team, especially Jason and Long, who do a lot to do the data cleaning and data management that facilitates all of this today. Thank you.